Welcome to today's deep dive, where we're going to be tackling a condition that I think keeps even the most experienced neurologists on their toes sometimes. Spontaneous intracranial hypotension, or SIH.
Yeah.
And we've got all the latest research lined up so that you can be completely up to date on how to diagnose and how to manage this condition.
Right. And this is something that I think is going to be really useful for a lot of our listeners out there, especially those who are working maybe in neurology or in emergency medicine.
Absolutely.
Because as you said, it can be a really tricky one.
Yeah, one of the things that I find so fascinating about this condition is that it can mimic so many other things. You know, patients often end up going from doctor to doctor to try and figure out what's going on.
Absolutely. And they get so many different diagnoses before they actually get to the root of the problem.
And even when you think about imaging, right? Like, I was reading a study recently.
Yeah.
Apparently, up to 20% of patients who actually have confirmed SIH have totally normal brain MRIs.
That's crazy.
It's crazy. So it really highlights just how important it is to really connect the clinical dots here.
Yeah, absolutely. A really good, thorough patient history is absolutely key. We really need to listen very, very carefully to how the patient describes their headache, how it changes with position and so, any other symptoms that they're experiencing, because often that's really the biggest clue that we have.
It's like detective work, isn't it?
It really is.
You're putting this puzzle together, and then one of the pieces of the puzzle that I'm always looking for is, well, what is the source of this leak?
Yeah.
You know, what are the spinal CSF leaks that are actually causing this problem in the first place?
Exactly. And I think, as you're saying, the leak is really the root of the problem.
Right.
And it turns out that not all leaks are actually created equally. Research has gone on to identify that there are 3 main types of spinal CSF leaks.
Okay.
And each of these has its own kind of sneaky way of draining this precious CSF that we need.
Let's unpack these different leak types, because I think understanding the nuances between them is going to be really helpful later on when we talk about imaging and treatment strategies.
Absolutely. So the first type is called a ventral dural tear.
Okay.
And this is often caused by something that's actually surprisingly small.
Okay.
It can be a tiny bony spur or even a calcified disc herniation.
Interesting.
So it's amazing how such a seemingly insignificant thing can actually lead to such debilitating symptoms.
So it's like a tiny pinprick
Exactly.
in a bicycle tire.
Yeah.
But instead of air leaking out, it's your CSF slowly dripping out.
Yeah, that's a great analogy.
Okay, so that's our ventral dural tear. What about leak type number 2?
So leak type number 2 involves a leaky nerve root sleeve.
Okay.
And often this is at the site of something called a meningeal diverticulum, which is essentially a little pouch or a bulge in the membrane that surrounds the spinal cord.
And are these diverticula, are they more common in certain areas of the spine, or is it sort of a wild card in terms of where they pop up?
It's a good question. So while they can occur anywhere along the spine, we do tend to see them a little bit more frequently in the thoracic spine.
Okay.
So knowing that anatomical preference
Yeah.
can be really helpful when you're looking at a patient's imaging.
So that's 2 leak types down. What about number 3?
Okay, so number 3 is perhaps the trickiest of them all.
Oh.
This is a CSF venous fistula.
Okay.
And it's basically an abnormal connection between the spinal fluid space and a nearby vein.
Okay.
So instead of the CSF leaking out,
Right.
it's actually draining away internally.
So it's almost like a hidden pipeline
Exactly.
that's diverting the CSF away from where it's supposed to be.
Yeah.
No wonder these are tough to catch.
They are very difficult to diagnose clinically and even on imaging.
And I imagine that's partly because of that silent drainage, right?
Yeah, exactly.
You're not seeing that obvious leak. Okay, so we've got our 3 leak types.
Yeah.
We know that the hallmark symptom of SIH is that postural headache. Worse when upright, better when lying down.
Right.
But what are some of the other ways that this condition might present? What other clues should we be looking out for in our patients?
So aside from the headache, you might see dizziness changes in hearing, even cognitive difficulties.
Really cognitive difficulties, too.
Yeah.
It's amazing how many different ways this can affect people.
It really is. And I think that's what makes it so fascinating, but also so difficult to pin down.
Yeah.
Because it can really present in a myriad of ways.
It's such a chameleon, clinically speaking.
It really is.
Right.
And it's a good reminder that we need to keep a very broad differential diagnosis in mind.
Absolutely.
Especially when we're dealing with these kinds of complex cases.
Speaking of complex cases, I'm curious, how often are we seeing those classic textbook presentations of SIH?
Right.
versus these more unusual presentations that might throw us off the scent a little.
Yeah, it's interesting that you say that there's actually been some interesting research on this recently, it seems, that a lot of the time we think about that classic presentation, right?
Right, like it's so clear-cut.
Yeah, the patient's telling you,
A textbook.
my head hurts when I stand up and it gets better when I lie down.
Yeah.
And you're like, aha, I know what this is.
Right.
But in reality, it's not always that straightforward.
Right. Are there any red flags that we should be aware of, even if the presentation is a bit atypical?
Yeah, I think one thing that often stands out to me is the timing of the headache.
Okay.
So patients will often describe their headache as positional,
Right.
but they might not always connect it specifically to standing up.
Oh,
For example, they might say, my headache is always worse in the afternoon.
Right.
And you're thinking, well, okay, that seems kind of random.
Yeah.
But then when you really start digging a little deeper, you realize, well, maybe that's when they're most active.
Right.
Maybe that's when they're spending more time upright.
They're going about their day.
Exactly. And so it's really about teasing out those details of the history.
Those little subtle clues.
Exactly. And don't forget about those less obvious symptoms, too.
Right.
So, if you have a patient who's coming in with new onset hearing loss
Okay.
or dizziness,
Mm-hmm.
especially if it's accompanied by that orthostatic headache,
Right.
SIH should definitely be on your radar.
Right. It's keeping that broad differential in mind.
Absolutely.
Now, we know that imaging plays a really key role in diagnosing SIH.
Yeah.
We talked about those pesky normal brain MRIs.
Yeah.
But even when the MRI does show some abnormalities, they can be very subtle.
Yeah.
So what are some of the things that radiologists are looking for?
So one of the findings that we see pretty commonly is something called diffuse pachymeningeal enhancement,
Okay.
which essentially means that the dura, the membrane that surrounds the brain and spinal cord,
Right.
is thickening
Okay.
and enhancing with contrast.
So it's like it's irritated and inflamed because of this leak.
Exactly. It's a non-specific finding. But in the right clinical context, it can be a helpful clue.
It's another piece of the puzzle.
Exactly. And then there are findings related to the leak itself,
Right.
although these can be more difficult to spot.
Right.
So radiologists will look for things like fluid collections in the spine,
Mm-hmm.
particularly extending along the nerve roots.
Oh.
They might see evidence of venous engorgement, which can be a sign of a CSF venous fistula.
I imagine that experience plays a big role here as well.
Oh, absolutely.
The more familiar a radiologist is with SIH imaging,
Yeah.
the more likely they are to pick up on some of these subtle findings.
You're absolutely right. And that's why I think it's so important to have a good working relationship
Yeah.
with your radiologist,
Absolutely.
especially if you're suspecting SIH in a patient. Having that open communication,
Right.
being able to pick up the phone and say, hey, I've got this patient, I'm a little bit worried about this, can make a huge difference.
It's a team effort.
It is.
Now, what about myelography? We mentioned that briefly earlier. As a way to help pinpoint these leaks, when should it be used?
Sure.
And what types are there?
So myelography is essentially a specialized type of imaging
Okay.
where we inject contrast dye into the spinal canal.
Mm.
And that allows us to get a much better visualization of the spinal cord and the CSF space.
So we're giving the radiologists a magnifying glass to really hunt down these leaks.
Exactly. And it's particularly helpful when that initial MRI is inconclusive,
Okay.
or if we need to get a more detailed roadmap to guide targeted treatment.
Okay, so it's not just for diagnosis, it can actually help us with the treatment planning as well.
Absolutely. Now, there are different ways to perform myelography.
Okay.
So one method is called dynamic CT myelography.
Okay.
And that involves injecting the contrast and then taking a rapid series of CT scans.
Mm-hmm.
And that allows us to see the flow of CSF in real time, which can be really helpful in identifying those high flow leaks.
So we're actually watching the CSF leak out
Yeah,
in real time.
exactly. It's pretty amazing technology.
That is amazing.
Then there's another technique called digital subtraction myelography, or DSM.
Okay.
And this technique uses a special type of X-ray imaging that essentially subtracts the bones and other surrounding structures
Oh, interesting.
so that you can see the contrast dye more clearly.
Wow.
It's particularly good at detecting those slow flow leaks,
Oh.
like a CSF venous fistula,
Mm.
that might not be visible with other methods.
So it sounds like with all these different high-tech imaging options, we have a really good chance of pinpointing these leaks.
Yeah,
But then comes the big question, how do we fix it?
right.
What are the treatment options for SIH?
Yeah.
And how do we decide which one is the right fit for a particular patient?
So the good news is we have a range of tools in our arsenal,
Okay.
from very conservative management to more targeted interventions.
Yeah.
And I think the first step is really assessing the severity of the leak
Right.
and the patient's overall health.
Makes sense.
Because for some patients, conservative management might be a reasonable first-line approach.
And when we say conservative management, are we talking bed rest, fluids, caffeine?
Exactly.
Okay.
It might sound very simple,
Right.
but encouraging rest hydration, even a little bit of caffeine,
Yeah.
can be surprisingly effective.
Interesting.
For some patients, especially if that leak is small and their symptoms are relatively mild.
It's like giving the body a chance to kind of heal itself.
Precisely.
Yeah.
But of course, for many patients, more active intervention is going to be necessary.
Right.
And in those cases, the gold standard treatment is often an epidural blood patch.
Okay, let's talk about epidural blood patches for those who might not be as familiar.
Sure.
Can you give us a quick rundown of how they work
Yeah.
and what their track record is for treating SIH?
So an epidural blood patch is a procedure where we take a small amount of the patient's own blood
Okay.
and we inject it into the epidural space, which is the space that surrounds the dura.
Okay.
And the idea is that this blood will act as a sort of internal bandage, plugging that hole and allowing the dura to heal. It's a relatively safe, minimally invasive procedure with a pretty good success rate for SIH.
So it sounds like they're a pretty powerful tool to have in our arsenal,
Yeah.
but are there cases where a blood patch might not be enough? And what are our options if that happens?
Yeah, you're right. Blood patches, they're not a cure-all, unfortunately.
Right.
Sometimes the leak is just in a really tricky location to access.
Yeah.
Or sometimes the first patch just isn't successful.
Okay.
And, if that's the case, then we might start thinking about targeted therapies.
Okay, so this is where those different myelography techniques we were talking about come in handy
Exactly.
to help guide that treatment.
Absolutely. So we can use imaging guidance to deliver a patch material, like fibrin glue,
Okay.
directly to the site of the leak.
Wow.
So it's a much more precise approach than a traditional epidural blood patch.
Wow, so it's like we're performing minimally invasive surgery.
Yeah, in a way.
Guided by real-time imaging that's incredible. Are there certain patient factors that might make us lean towards one of these targeted therapies over a traditional blood patch?
Yeah, absolutely. So for example, if a patient has had multiple blood patches
Right.
and they just haven't been successful,
Okay.
a targeted approach with fibrin glue might be a better option for them.
Okay.
Or if the myogram shows us that the leak is in a really difficult spot, like high up in the thoracic spine,
Right.
that might be another situation where we would consider a more targeted approach.
It's incredible how these tools and these techniques are always evolving.
I know, it's amazing.
It gives us more options for these really challenging cases, but I imagine with any procedure, there are potential complications
Of course.
that we need to be mindful of.
Absolutely. It's really important to have a thorough discussion with the patient
Yeah.
about, the potential risks and benefits of any intervention.
Right.
With epidural blood patches, for example, there's a small risk of infection, bleeding, just like with any procedure.
Why, of course.
And then we also have to be aware of the potential for something called rebound intracranial hypertension.
Rebound intracranial hypertension. Now, isn't that a bit counterintuitive?
Yeah, it seems a bit backwards, doesn't it?
Because we're trying to increase CSF pressure with these treatments.
Exactly. But what can happen sometimes is that when we patch that leak
Yeah.
and the CSF pressure starts to rise again, it can kind of overshoot the mark.
Interesting.
And that can actually lead to a headache that's worse when lying down.
Oh, wow. So it's like the body's plumbing system is trying to recalibrate itself.
Exactly. And it just needs a little bit of time to adjust.
After that sudden change in pressure.
Precisely.
That's fascinating.
And it highlights why close monitoring after these interventions is so important.
Right.
We want to make sure that we're not just chasing symptoms,
Yeah.
but that we're actually addressing that underlying problem.
Right. Restoring that balance.
Exactly.
It's amazing to me how a condition that seems like it should be so straightforward.
Right.
It's a leak.
Yeah.
A leak in the system.
But it can actually be so complex.
Oh, absolutely.
Well, this has been a fascinating deep dive into SIH, as always.
It has.
As we wrap up, are there any final key takeaways you hope that our listeners will walk away with today?
I think the biggest thing is just remembering to consider SIH in any patient who comes in with that postural headache.
That's a good point.
Don't be afraid to dig deeper.
Yeah.
Ask those really detailed questions about their symptoms. And, consider ordering those specialized imaging studies if you have that gut feeling that something's not quite adding up.
Trust your instincts.
Exactly.
And I think this discussion has really highlighted just how crucial it is to stay up to date
Yeah.
on the latest research and the latest treatment advances.
Absolutely, because this is a field that's rapidly evolving. There
Yeah.
are new insights and techniques emerging all the time.
Yeah.
What we know today might be different tomorrow.
Right.
And that's what makes it so dynamic and so fascinating. Couldn't have said it better myself. Thanks to everyone for joining us for this deep dive into the world of spontaneous intracranial hypotension.
It's been a pleasure.
Remember, knowledge is power,
It is.
especially when it comes to tackling these tricky conditions.
Absolutely.
Until next time.
See you then.